exercise therapy for chronic pain. I'm going to jump over that. Basically, I want to go right into behavioral principles in exercise therapy. And the reason for this is that, and by the way, this will be focused on low back pain. It's a problem that has been studied quite a bit, so we have more evidence than we do for other problems. And I think it's just sort of a paradigmatic condition. And I want to talk again about behavioral principles in physical therapy, and I want to just set the stage. Physical therapists, for whom I have great respect, but their training is really more in the biomechanical aspects of musculoskeletal problems and the biomechanical aspects of exercise therapy, and that is great. We need that expertise. Then and many of them, most of them, feel most comfortable in talking about biomechanics and how people are activating their core muscles when they exercise and how strong the multifidus is and so on. And those are appropriate. Sometimes physical therapists will create a program for low back pain that is biomechanically not a good idea. And I give an example, I've seen this quite a bit, where they have older patients engage in hyperextension exercises where they extend their back as far as they can. Many older patients don't tolerate that. So I give that as an example of what I would consider a biomechanically incorrect physical therapy program. But in general, I think the therapists do a very good job in terms of dealing with body mechanics and sort of musculoskeletal biomechanical factors. Another related point is that there are many correct programs, meaning that when comparisons are made between different types of exercise programs, so we're talking about Pilates or McKenzie type exercises, spine stabilization programs, general conditioning programs, when they are compared, basically it's been very hard to show that one is better than another. So that the therapists can approach the biomechanics of a problem in different ways and seemingly get different outcomes. And I didn't put in this just for brevity, but a related point is that when people have looked and say, what is it that really works about physical therapy? It turns out that there isn't really strong evidence that changes in biomechanical factors like strength of the abdominal muscles are that strongly associated with correction of disability. What seems to be the most important ingredient in exercise therapy is a restoration of the patient's confidence that they can use their body. And that's a general statement, but it seems to stand up fairly well in the literature. So the big problems, and the reason why we have to think about behavioral issues, the big problem is to get the patients to do anything. And our pain patients, many of them are so traumatized by the idea that maybe they will do something that will aggravate their pain, that they become resistant. Many of them had very poor exercise habits before they were ever hurt. So in trying to get them to be health enthusiasts, we're basically trying to get them to change lifestyles that they've had all their lives. So it's difficult to get them to exercise. It's difficult to get patients to persist in the face of flare-ups, and I will come back to that because I think that's the key point. And it's difficult for them to take charge and do self-directed exercise. So overall, the point that I'm making here is that I think behavioral issues in exercise therapy are more important than biomechanical issues. That's not to say that biomechanical ones are unimportant, but the behavioral issues are the key things. So what is it that we need to do as we think about behavioral issues in physical therapy? One thing is to educate patients. They need to know, and I'm giving a bunch of terms here that I'm going to talk about later, but patients need to get smart. They need to understand their bodies better. They need to have strategies for managing flare-ups, and I keep coming back to this because I think it's a very important point. They need to have reasonable expectations. It's not uncommon, the patients that I see, the patients will come in and say, well, I went to one physical therapy session and I wasn't better, so I quit. They have to understand that exercise therapy is an investment in the future. You work hard now, and you anticipate that you will be better 6 months from now. Now, which exercises? There are many exercise programs, as I said, for low back pain. a key point is what I would call an exchange list. I just made this up with an analogy to the Americans with Diabetes Association diet, where they talk about exchanges between foods. But you can get exchange lists of exercises, meaning that there are different exercises that accomplish the same biological goal. And it's important for a patient to choose those exercises that achieve a biological goal but are better tolerated. So I just give examples here. Somebody corrected me on this, and I said, I asked, what's the common thread? What's the commonality here? I was thinking aerobic exercise. Somebody else said, this is a triathlon. So, but at least to me, the common thread here is that these are aerobic type exercises. Here are two exercises that basically involve flexion of the lumbar spine. People will generally tolerate sitting in a chair and bending forward better than they will tolerate bending forward from standing up. So this would be an example where you might have a patient who has good difficulties standing and flexing, but maybe they can get started by sitting in a chair and flexing. This one is a little harder to interpret, but they're both different types of exercise that strengthen the abdominal muscles. Again, the broad point is there are different ways to accomplish a biological, biomechanical goal, and the issue in an exchange list is to choose those exercises that the patient tolerates. If you have a choice, I would say exercises that can be quantified are better than exercises that cannot be. And I give an example of sit-ups. You can say how many sit-ups a person does versus isometric abdominal exercise, which certainly can strengthen the abdominal muscles, but you can't see it. You can't measure it. You can't say how many of these a person is doing. Okay, another concept in the behavioral approach to exercise therapy is the concept of a baseline. A baseline, by definition, is a level of intensity of any exercise that a person can tolerate without having some adverse effects. And this is important because over and over again, when I talk to patients, I find that they started an exercise program, they went way beyond their ability, they had a flare-up, and then convinced them that exercise is a terrible thing for them. And I've seen physical therapists who push patients very hard at the get-go, and then again, the patient blows out of the program within the first session or two. And in these situations, it's very important to get the therapist and the patient working together to say, let us start very slow. Let us establish what you can do, and then build from there. And this may sound so obvious, but I will tell you this is one of the major reasons why exercise therapy programs fail. Now, a baseline is needed for each exercise. So if you establish a baseline in one exercise and not in the others, the person is still going to have a very difficult time. A baseline is easiest to define and to explain to a patient if you can quantify the exercise. That gets back to the other slide, the previous slide, that exercises that can be quantified have the advantage that you can establish what the intensity level is and build from there. Sometimes it takes more than one session to establish a baseline because you have random effects. Sometimes patients are better on one day than another day, so it sometimes takes a little while to figure out what the baseline is. What about exercise progression? If you have established a baseline, let's assume a person can lift 15 pounds from the floor, and that you're pretty good baseline, you're pretty confident of that. What would you expect them to do over the next week or over the next month? How fast do you expect them to progress? You want them to go forward, but how fast? And I will tell you that there is no clear formula for this. There's nothing you can go to the literature and find out. I think that, in my mind, with our pain patients, we want to be careful of very aggressive progression, just as we want to be careful of very high baseline. So I suggest that a person try to increase about 10% over baseline in the first week of exercise, and once you or the physical therapist can watch how the person does in this slight increase, then you can get a sense of how fast you can go after that. Basically, when you have two data points, you can see how much progression and how rapid a progression the patient can handle. Another concept, and sort of behavioral concepts in exercise therapy, is the concept of maximal medical improvement. And basically, it embodies the reality that we all reach plateaus in performance. No matter how hard we try, nobody runs a 3-minute mile, nobody lifts 500 pounds. And so the issue is to work on an exercise program or each exercise in a program until the person has achieved maximal benefit. What's tricky with the pain patients is that some of them, as soon as they feel a twinge of pain, will say, that's it, I'm not going to do any more. And I would say that if we really want to find MMI for an exercise, we have to have the person get back and try over and over again to kind of push as far as they can push and see whether they can go farther than they did before. This is a difficult thing for patients who have pain problems because they tend to shy away as soon as they hurt. I'm going to jump over that. With maximal medical improvement, it's basically you can talk about maximal medical improvement for a specific exercise, or if a person is on a program that, let's say, has 6 exercises, you can talk about they've reached maximal benefit from the entire program when they have achieved MMI for each exercise in it. Another behavioral concept in exercise therapy is the value of giving feedback to patients. When we had our pain rehabilitation program, we would have people keep charts and graphs where they would write in something to show how much they're doing of a certain activity, how many minutes they're walking, how many pounds they're lifting. And we found this extremely helpful. Patients find it very gratifying when they see that they are improving. So this is another behavioral strategy that is very effective. Another issue in the behavioral concepts in physical therapy, in my mind, is when should a program be terminated? I think that we sometimes, as physicians, we fall into the trap of allowing therapy to go on and on and on without any clear endpoint. And I would suggest that there should be some definition of what represents a successful conclusion of a program, and I would consider 4 variables. 1, has the patient reached maximal medical improvement in the exercises in the program? What do they understand? Have they learned what they need to learn about biomechanics, about exchange lists, about baselines? Do they understand basic concepts so that they can manage themselves? Do they have strategies for managing flare-ups? And do they have a commitment to a home program? Those are my criteria for successful termination or successful completion of a PT program. And so it is important in my mind and for us as clinicians to be aware of these criteria and to think about them when we decide whether a person has succeeded in a physical therapy program. And it's important to recognize that success in physical therapy is not the same as clinical recovery from a back problem. A person may have put their heart and soul into a physical therapy program, done everything right, and yet they continue to have back pain. And I think we as clinicians sometimes set the stage in a way that doesn't work because we assume if the person has not recovered, then they haven't done their job in physical therapy. They are not the same thing. But at the same time, I think we have to avoid accepting the patient's statement that physical therapy has failed. I can't tell you how many times I have heard that. So the person says physical therapy didn't work. I think we need to assess where they are. Did they get started on an exercise program at all? Did they reach maximal improvement? Do they understand why they're exercising? Do they have strategies to deal with setbacks? Do they have a home program? So we need to assess these things rather than accepting a global statement, physical therapy failed. But conversely, if a person has successfully completed a physical therapy program, I think we should stop sending them back again and again. And I do this sometimes. I think other clinicians do. We don't know what else to do, so we send the person back for the 8th program of physical therapy. We have to decide when they've gotten all they can from that approach. So some practical strategies for you as clinicians who are managing patients who are going to physical therapy. I think it helps to get to know a physical therapy group or several physical therapy groups. You do a better job of co-managing a patient if you work together and know each other. Question of orders. How specific should orders be? This is a bit of a controversial thing. I'm a believer in writing fairly generic physical therapy orders. I don't see a lot of harm in that, although some would object. Won't go into the history there, but when I was a resident, we were told to write pages worth of orders for physical therapy. I don't think that's necessary. I think the physical therapists are they are professionals. I'd like to give them some room to make decisions rather than try to micromanage. Also, it is, though, important to emphasize that the physical therapy should be an active program. I will sometimes write to say modalities are okay as an adjunct if I think a patient will have a hard time getting started, but we don't want people simply going to physical therapy and getting hot packs put on them. I do think that if you write general orders, or even if you write specific orders, follow up with a physical therapist is important. Then when you get some feedback from the therapist of how things are going, you can work on changing the orders, making them more specific, changing them in various ways. Another practical strategy, I think interaction with patients is just crucial. To me, one of the biggest mistakes we make as clinicians is to send people off to physical therapy and simply never mention physical therapy again. And so the interactions with patients include education before the physical therapy program starts. I think this is very important for patients who have failed physical therapy in the past. Don't just send them back. Talk to them about what went wrong. Give them some ideas about how to succeed. I send patients a paper on exercise therapy before I send them back to PT. Once they're in physical therapy, ask about how they're doing. If you ignore the physical therapy, they'll conclude it's not important. Have the patient demonstrate the exercises. This is really unbelievably informative because many patients, you ask them to show what they're doing, and basically they say, I have no idea what I'm supposed to do. Another thing in terms of interactions, don't accept global statements like physical therapy is terrible. Go get into the details. What exercises are terrible? Manage flare-ups. I just think this is important because, at least in my experience, patients can do well for a period of time with whatever treatments we're providing, but so many of them are so ill-prepared to deal with setbacks. They basically panic and get away from whatever rehab they were doing. So it's very important to anticipate flare-ups and to work with them. So managing flare-ups, they will occur, at least in my experience, and they're hard for everybody to figure out what's going on. The patient says, I hurt more. You as a clinician often don't know what's going on. The patient is confused. The therapist is confused. It often leads these people to quit physical therapy. The patients will tend to panic when they are experiencing increased pain. So what kind of evaluation do you do? I think the first question is, does the flare-up have anything to do with the exercise program the patient is in? People can get flare-ups for different reasons. They change a tire on their car. I mean, so we don't want to jump to the idea they have a flare-up, therefore there's a problem with the exercise program. If you decide that it's the exercise program, which exercise was the problem? Here it does help to know something about exercise therapy yourself, but even if you're not so familiar, you can still have the patient demonstrate exercises and ask them which one they think is bothering them. And what I believe in is, I'll call it an elimination diet. If a person is on 5 exercises and they say that 5th one is the one that's killing me, say, okay, go for 2 weeks without doing that one, but do the others and see what happens. And you can, by eliminating certain suspected exercises, see which ones are really causing the trouble. If you locate or localize which exercises seem to be the problem, then you have the question of how important is the exercise? Is it possible to do some exchange, to have the person do something different that does the same biomechanical goal, or reaches that, but is less stressful? I would distinguish in talking about changes in exercise after when one seems to be offending exercise. I think that with aerobics and strengthening, I think that you really do need to take the idea that a little pain is okay. No pain, no gain. With stretching and skill-building exercises, I would take a very different approach because people will not do well if they're trying to stretch when they're in pain because everything will tighten up, and they don't build skill when they're in pain. But so to some extent, the type of exercise determines how you respond to the idea that it's causing problems. How serious is the flare-up? What are the functional consequences? Are there associated clinical findings? Does the person who's complaining of knee pain now have a swollen joint? Does the person who complains of increased back pain now have evidence of sciatica? I mean, you want to kind of look at all the things that are going on. You have to decide, are you going to do some medical workup? Maybe the patient needs a new scan or some other test because you think their status has changed. Are you going to do something to basically reduce their pain, some sort of passive therapy, massage, injections, medications? what are your options for exercise? And one thing is just say, tough it out. Maybe reduce the intensity. Maybe try a different exercise from an exchange list. Maybe drop the exercise entirely. But all of these are choices that as clinicians you need to be thinking about when people have trouble with an exercise program. You need to give them messages that hopefully help them deal with a flare-up without panicking. The notion of hurt versus harm. In chronic pain situations, people will often feel pain, but when they're really not, making their situation worse. This is a tough sell for patients, but pain is an opportunity. Our patients don't generally feel blessed by their pain, but sometimes you can at least point out to them that they can learn something from their pain. I wouldn't emphasize that one because that's a hard sell. I think it's important for the patient to stay calm and to work through the problem, not to panic and run the other way. And I think that you as a clinician should model this kind of analytic, problem-solving approach, because when people problem solve, that tends to inhibit panic and excessive emotional reaction. Now, all of this, it sounds to me, well, I like it, it sounds good to use all these behavioral principles, to interact with your patients, to educate them before they go to physical therapy, to review carefully their exercise program once they're in physical therapy. The problem is this takes time. And in the world we live in, it's hard to get the time to do a good job on this. But the challenge is if we don't work carefully, if we don't treat this exercise program as a very important part of the person's rehabilitation, the exercise program is likely to fail. Now we've got a failed patient, and that's even worse. But it is truly a dilemma. I think we all struggle with this issue of how to spend the time we need to make sure that our rehabilitation efforts are appropriate. I don't have a good solution, but I would say that it is important for you as a clinician to invest time and resources into making sure that exercise therapy works. And I'll stop there.